Wow. Well, I mean, it's been something nobody expected at all to happen, hasn't it? And it's sparked some of those community responses that I think traditionally have been conjured up in times of war or conflict.
Hackney, I would say, was one of the quickest systems to mobilise across East London.
It was all about making sure that the NHS had capacity and that there was enough PPE and that people knew how to use the PPE and all that kind of stuff.
The preservation of human life. That was the top thing, was, are we making sure people can feed themselves?
Predominantly about ensuring that we are able to continue to provide safe services for those most at risk in a way in which is safe for our staff. And
people put aside those usual questions of, am I allowed to do this, and who will pay for this, and what will happen if I do this, and they just got on with it.
People have really kind of pulled together and worked incredibly hard, for the common good, really, and under a very challenging situation.
Right at the very beginning, I suppose it was that kind of scaling up, what we were going to do in terms of entering lockdown and those very new ways of working.
I was struck by Hackney local authority getting the national food parcels through for the shielded population, and then making a decision that those food parcels were not something they wanted to distribute to their residents, and they went about sourcing a different set of materials.
What COVID has done is provide a very clear common purpose, and in many respects it's demonstrating, or has given the opportunity to demonstrate, integrated care partnerships in actual practice.
This government direction came down at the end of March, and extraordinarily everyone who the hospital said they don't need to be here anymore was then housed somewhere else within 3 hours.
We saw the main priority as trying to make the rapid discharge as safe as we possibly could.
Getting people out quickly and putting social care packages in it has happened quicker, and that the finances have been there to do that. They've been allowed to do that, but it's meant that things have come back to primary care a lot quicker as well.
So part of our team, who normally would be helping with contracts and things, we got them to become a sort of COVID support team, so that any practice with any worries about how to do stuff, how to manage, not having enough IT equipment, all that sort of thing, they could just contact us. We had set up this doorstep assessment service for people who might need to go into hospital. We didn't want to be bringing them out if we didn't need to because of infection, but we did need to make sure they were safe.
And the second big change is the dramatic change in how primary care has operated.
In our practice, we were already operating a sort of a triage telephone first system already, but that has become very much obviously the norm across the system. So doing 90% of our work over the telephone or over video. Then when we do see people, seeing them in full PPE gear, and that's a very different experience. Obviously, it's been very difficult holding things in primary care that we would normally refer on, not being able to get investigations done. And I felt a sense of support. So even within my practice, I feel like we're talking more and supporting more. And then within secondary care also, we've been using the advice and guidance service, and the amount that I've been using it has gone up by 10. I mean, it's 5 to 10 times. I mean, really feeling like you're managing the patient together.
The light has been shone very brightly on what the voluntary sector can do at a local level that nobody else can. Who they can reach, what they can learn, how they can support people, what they can find out that we can't find out.
So right from the beginning, we worked very closely in partnership with the council. They were asked to set up something called a volunteer hub.
Clearly, from the beginning, we had 3 different areas of work. One was our frontline service. The other was our food distribution service, which we started very, very quickly. And then also our kind of telephone and virtual work.
This has been a really good opportunity for the voluntary sector to be particularly smaller grassroots organisations to be really clear and say, no, this is vital stuff. this is the glue of communities.
The voluntary sector stepped in, so core arts and sports stepped in, started running brilliant online classes. They did an online hip hop class, which I've done. It's fantastic.
There's been a lot more direct partnership working and a lot more communication than there's ever been, which has been amazing. You know, the fact that we have these fortnightly meetings with the mayor, I mean, nothing gets decided there, but on the other hand, it's nice to know that we've got his ear.
A lot of what I've been doing with my team and with obviously community support is setting up 8 neighbourhood teams and then wrapping around that sort of virtual multi-agency meetings to discuss patients that have particularly complex needs. So for our neighbourhood teams and neighbourhood MDTs, you know, we were having lots of difficulties before about getting different organisations and professionals in the same place. So it's been great, particularly with some of those specialist support services, where we've had like a specialist consultant who's been able to drop into that conversation because it's been happening virtually.
And of course, this is a revolution, isn't it? And I mean, I've had some MDTs with sort of 5 or 6 different people, you know, an OT and a social worker and a this and a that and the other. And we've all said, well, wait till we set this up. And before I thought, I can't go to that. I haven't got time. But now I can think, yeah, I can fit in half an hour.
So we've got a kind of paradoxical situation of mental health getting worse, and yet people not coming forward. So most of what I've been involved with has been reaching out either by texts, letters, leaflets, advertising, websites, short films. All of our psychological treatments in IAPT are now online, and I think that we're developing further innovation with apps and all kinds of stuff on phones.
If someone said to me pre-COVID we'd end up with 90% of our rough sleepers actually in accommodation, I would have said to you, no, we're never going to get there. We've done it. Now the struggle is how we manage to retain people within suitable accommodation and pathways and have the health support and wraparound provision.
We've been working over the last 18 months on the Wells Street Neighbourhood Partnership. Yes. COVID happened. It was like, right, there's an expectation and big pressure on us to suddenly roll out that neighbourhood approach to the other 7 neighbourhoods. So we started a series of neighbourhood conversations that brought together frontline practitioners, people who worked in GP surgeries, counsellors, voluntary organisations. And I think we then used the findings of that to drive further knowledge about the impact of COVID within the council and CCG.
I think with the changing system and doing everything virtually, that there is a big potential to widen inequalities, which I really worry about.
The focus on inequalities in health, I think COVID has starkly reminded people it has had a disproportionate impact.
And what we actually need to do is really go underneath and think about why those inequalities exist. And I appreciate that some of that work's already happening through the inequalities work stream, because there are things that we do as a system, the way that we treat people, the way that we simply think very differently about different groups of people, that then results in them getting different outcomes.
And the digital divide mirrors an economic split that seems to be getting worse in our society. And then that's a big deal for mental health.
The virus hasn't gone away, as you know. There will be outbreaks, not necessarily in Hackney, but there will be outbreaks, and it's very likely to be a second wave.
We just need to be prepared and planning for the sort of the perfect storm of COVID and flu, and of course, you know, the impact of COVID to date, all happening and sort of coming together around that time, and potentially, if you know, for example, schools are going to be going back in September, you know, the impact of what that looks like.
I think we've always in City and Hackney intuitively known that neighbourhoods was a logical framework for organising services around people.
Doing contact tracing at neighbourhood level, whether that's with voluntary sector partners or some other system within the neighbourhood, might actually be key.
You know, in some ways, it's a bit cliche, it was the burning platform that we needed.
in a way.
There was a very clear shared purpose, and that shared purpose wasn't delivering what NHS England wanted. You did that. It was, protecting the NHS and saving lives. I know it sounds a bit corny, but that's what it felt like.
What COVID-19 did is it broke down a huge number of barriers, and actually it brought together people who hadn't worked together in this way before. And the question was, what did we need to get done? When did we need to get it done by, and how were we going to get it done? Regardless of what group, what board, what structure, what meeting that things had to go to.
We should have an action plan, and we should kind of make a list of all of the things that we really need to make sure that we need to be on top of. We don't need endless long reports from everybody back to us assuring us. We do get something back here. It needs to be 2 sides of A4. We really don't have time for huge reports.
There's papers available normally the night before SOC, which was quite challenging when it was twice a week. They were very clear where they were designed to be exploratory or to move things forward, but always kind of very focused on, and what do we need to do next, and what haven't we considered, whose voices have we not considered.
The GP Confederation needed to set up a hot hub, and they were looking for different areas to do that, and they'd had a couple of suggestions. When I saw the suggestions, I was able to sort of say, oh, well, maybe we could use John Scott Health Centre, because that might be better for you. And we were able to then progress those discussions really quickly. They got set up over there. We moved out to allow them to have the space. And it was the sort of thing that if it hadn't been in the middle of a pandemic, it would have taken us an age to have agreed.
I mean, I saw people working at the top of their game, say, okay, I'll take this away and do it. And then 2 days later, like, we've done this, we've got these people together, we've made this happen.
I suppose the learning from SOCDs, though, is that actually you can achieve quite a lot without, with a governance light type of approach, recognising that, the sorts of things that have been put in place is because of people trusting each other. Actually,
we've never had conversations about finance at the SOC, because essentially all the contracts were turned to kind of block contracts. All of the issues have not been around we haven't got enough money. The issues have been around using the resources in terms of people.
I mean, this is not a sustainable way of working, and people's health and well-being, and you can't carry on like this. But the difficulties were that the sphere around the SOC, who perhaps weren't fully immersed in that, there was a bit of a disconnect in terms of ways of working.
People who are helping with the pandemic, who can do things to help, feel very valued, because what they're doing is making a difference, it's saving lives. But there are other people who are more connected to, say, business as usual, which has now stopped, who now feel less competent and less valued.
So the relationship's been strengthened just because people have had to kind of really intensely work together and figure things out. And I think it's also kind of created a bit more of a can-do attitude.
I have concerns around if SOC is moving to a broader delivery mechanism around the political accountability of that, and the fact there isn't any political representation, and it is overwhelmingly health-focused.
I think that the Zoom technology, there are pros and cons to that in terms of running, a good discussion which you can have a vigorous debate, etc. And explore ideas, but it does really lend itself to discussions with smaller groups of people, really easy access to people. Can I just quickly, the 4 of us get together and we can just really work this out, etc. Yes, fine, let's do it tomorrow morning at 10:30, because no one's travelling, so they can just fit in half an hour or whatever, whatever it means. So all that stuff has worked really well.
At North East London, there's never really been a strong children, young people steering group. It's sort of limped along for quite a long time. And then through COVID, Kath Evans and Mark Scott kind of grabbed it, and it's been so helpful and supportive. And there's probably about 100 of us now, because it's across 7 CCGs.
One thing which I think has been very helpful is twice a week at 7 in the morning, the 7 CCG chairs meet for an hour.
You do need somebody to be accountable and held to account for actual delivery. And that doesn't mean, it's sort of you throw partnership out of the window, but ultimately there's only so much sort of distributed leadership you can have sometimes in these cases, which, in times of crisis.
there is a lot of talk and a lot of nice words around what happens in primary care networks and what happens in boroughs. There isn't a legal structure to help deal with that if you turn CCGs into sort of more strategic, wider area footprints. I think where things will get slightly more complicated now depends on how the acutes operate going forward. There's an opportunity for the acutes to collaborate far more with each other than they perhaps have.
So the health and wellbeing boards are the what in a very broad sense. So over the next 10 years, we want health inequalities to decline by this. And the integrated care board is the very practical nuts and bolts, more of a health focus, but a bit of social care of annual plans of how you deliver that 10-year agenda. And then the SOC is, right, how do we do this?
So I would suggest that the setting of the priorities and principles is something that sits with your health and wellbeing board, and the quality assurance of that all and making sure it actually happens is done at the health and care partnership.
If anything, if we can get them to reposition and look at inequalities in health, the barriers from a big picture. So your local plan. So starting off, so you're planning your housing, your redevelopment, what you're going to do in terms of your streets, your environment, environmental health, all those kinds of things, pollution. I think health and wellbeing boards will be better at pulling some of those levers and having those overarching big ticket things that we know will actually make the greatest impact on people's health.
I think there is something around the ICB in that bridging that gap from strategic to operational. I don't think that happens enough. In that strategic leaders will say, yes, we're fully behind this, but then you come to talk to their operational leads and they either haven't heard about it or are very resistant to whatever it is that the strategic leaders have developed. So I think a role of the ICB is, you've got the key strategic leaders there, but they need to be there bridging the gap.
And you have your provider alliance of your acute hospital and your GP confed and your broader, your ELFT, mental health and community support services. All do their best to provide that. And actually your integrated care partnership is where what has been determined by the broader health system and the health and wellbeing board is quality assured.
Yeah, as I say, trying to formalise some of those SOC-G accountabilities will be certainly the next phase.
And then I think there's a delivery aspect of that, which is essentially what used to be our work streams, but now needs to be something different and be equally owned and driven by the partnership, which is where I think there's an opportunity to think about a type of a neighbourhood health and care board sitting in a delivery space who mobilise resources to drive on with improvements for our populations.
That system has to be properly represented, and that means the voice of service users, it means the voice of marginalised groups in the community, it means the voice of smaller providers as well as the big providers.
In terms of where we go now, the key, I think, is reducing the siloed working, which the work streams have slightly created. Using the neighbourhoods, regardless of that I'm the neighbourhoods clinical lead, actually using that locality-based approach to care as one of the foundation blocks. That's social workers, that's therapists, specialist nurses, practice managers, practice nurses, working together to represent the people in that area.
We wanted to have people in the neighborhoods influence what our neighborhood was doing. Not necessarily, local elected officials, just people in the neighborhood. Decisions on, really locally delivering services, something that hearing from the local folks, not just the service deliverers, has proven to be quite useful.
And then there's this new concept that perhaps the PCNs working through the neighbourhood structures can lead on localized inequality plans, which I think will be really powerful and will galvanize our collective efforts.
Volunteering is very much part of community development. You can't develop communities unless you're working with individuals, and working with individuals is about them recognizing what their skills are and helping them express that and use them, and that is volunteering. It's just the term that I think people think is old-fashioned, but it's very much connected with that, and I would really like it if people recognize that.
Getting people kind of with long-term conditions being looked after in their communities, using the kind of the community assets that you have to kind of support them will be more helpful rather than get them going in and out of hospital.
You can't run neighbourhoods and networks separately, so how do you take all the powerful stuff and make it work for the networks in the neighbourhood, and it probably will have to morph into something slightly different.
We do need to make sure that people have access to high quality, good care safely in a community setting, and pulling those hospital services out into a community setting through the neighbourhoods construct does require trusted leadership in that setting. So I think there is an opportunity to think through the role of a hospital leadership team in making that happen, and marrying that up then with the rather excellent primary care leadership we've got, both through the ComFed but also the CCG as a member-led organisation.
From my perspective, I need one person. I need, that accountability to be quite clearly defined. Actually, part of that sort of single accountable sort of officer approach then is, has to ensure that they also lead in a way that is not going to sort of reduce any collaboration, but actually to sort of strengthen and build on it.
And I've worked in local government all my life. I've worked in the NHS for a number of years. I think I've learnt more about the NHS during COVID than I have in the years that I've worked in the NHS.
It's given us a glimpse of how we could do work and do things differently. And I think from a City and Hackney perspective, given the different components and the work that's been going on, over a number of years, really, all the building blocks were really in place, but it gave us an opportunity to test out and as I say, test it out in a successful way. Actually,
we've had a common purpose, and we haven't been not much. Have a little bit. We haven't been saying that this is some kind of tug of war over resources.
We've got to use this as an opportunity to not go back to the contract being the thing which determines the relationship between commissioners and providers.
I really do think that fundamentally we want to make sure that sort of top to bottom really do have patient voice representation.
We're not out of this yet, so this is something ongoing, and the learning will continue to develop. This is just one phase, so we've moved from. We're moving through phases, and we will learn as we go along. The bit that I suppose I will come back to, and it's where my mindset is at the moment. I know what I think I've delivered. I know what I think the system has done. That the feedback loop is missing.
I think if we use those as our starting principles, a relentless focus on outcomes and qualities, a relentless drive to involve and be led by our patients and residents, and a commitment to ensuring our resources and services are structured around clinicians and practitioners and co-owned and co-produced with all of those partners. I think those are our building blocks. We must not forget that pedigree and those genetics, that it is our DNA.